Good evening. Welcome to Together Facing Liver Cancer. Thank you for joining us this evening. I'm Dr. Jason Castellanos. I'm an assistant professor of surgical oncology at Fox Chase Cancer Center. Tonight, my colleagues and I will share the latest research and treatment developments for liver cancer. Throughout the program, please feel free to leave questions in the chat feature on Facebook. We'll get back to you later this evening. We may slightly modify the question you ask to make it as useful as possible for everybody. And if you've got very specific questions, we'll make sure to link you up with a treatment expert in that area so you can get your very specific question answered. We're really proud to be here tonight. Fox Chase Cancer Center has a long history of treating liver cancer. He was here that hepatitis B was discovered, and as well as the hepatitis B vaccine, which is the first anti-cancer vaccine. And Dr. Bloomberg won the Nobel Prize for that as well. And we continue to serve an area where hepatitis and hepatocellular carcinoma have a higher incidence than other places in the nation. So it's something we're very sensitive to and very proud to treat. Before we continue, I'd like to take a moment to honor those we have lost to cancer. So please join me for a moment of silence. Thank you. I'd also like to thank our exhibitors for this evening. It's because of their generous support that events like this are possible. Our gold exhibitors are AstraZeneca and Novartis. Our silver exhibitor is Eisai, and our bronze exhibitor is Exact Sciences. And thanks to their support, we're able to bring this wonderful program. And also special thanks to the American Liver Foundation and the Blue Fairy Adrian Wilson Liver Cancer Association. These are two organizations devoted to patients, helping them understand the disease and also driving research forward. So we really appreciate their support and involvement tonight and welcome you to learn more about them. I'd like to introduce our distinguished panel. I wrote them all into this and they all came willingly, and so I'm thankful for that. I'll just go in the order of the Zoom I see. Dr. Ken Chauvin is the head of liver transplantation and solid organ transplantation at Temple, and we're really thrilled to have him here tonight, and he'll give you a perspective on how he treats liver cancer. Dr. Dina Yofi is one of our medical oncologists who treats patients both at Temple and at Fox Chase. And so she helps those patients who need systemic therapy for liver cancer, and so she'll tell you more about that. Dr. Joshua Meyer is one of our radiation oncologists. He treats patients with liver cancer as well, and oftentimes in combination with many of us. Dr. Min Nguyen is our hepatologist on the panel. She is not only treating patients with liver cancer, but any kind of patient with liver issues or dysfunction, even those patients who are at risk for liver cancer. And finally, Dr. Jared Meshikow is one of our interventional radiologists, and they often are one of the main people who treat liver cancer, interface with these patients even repeatedly. So he'll give you an insight into the things he can do for liver cancer patients. And so with that, I'm going to turn the panel over. I'm going to turn the mic over to Dr. Nguyen, who will give you her perspective as a hepatologist.
Thank you, Jason. Hello, good evening. My name is Dr. Min Nguyen, and I'm a hepatologist at Fox Chase Temple Cancer Center. Thank you for joining us this evening to discuss a very significant topic in oncology, which is liver cancer. So as you may know, the incidence of liver cancer is on the rise, and the major drivers include viral hepatitis B and C, alcohol, and somewhat a newcomer we call the metabolically associated fatty liver. Any combination of these factors can cause accelerated liver disease and liver failure. For viral hepatitis, the current guidelines from the CDC recommend at least screening for everyone who works in the office for both virus. We have highly effective hepatitis B vaccine for the one who's not immune and doesn't have an infection, and also effective medication for hepatitis B to be treated chronically at this point. Hepatitis C treatment is highly effective, but unfortunately, they do not offer immunity, and we do not have an effective hepatitis C vaccine. As turn to alcoholic liver disease, during the COVID pandemic, that seemed to be on the increase. And this, of course, may lead to an increase in alcohol-related liver disease. And psychotherapy and detoxification offer some relief. The metabolic syndrome is somewhat new, but it's been around for many years. But we have learned more about it. And it's actually a systemic disorder that affect multiple organs, including the heart, the brain, and the liver. It consists of 4 major factors: obesity, usually with BMI above 27, hypertension, hyperlipidemia or hypercholesterolemia, and prediabetes or diabetes mellitus type 2. Any of these factors or combination of them could lead to the metabolic syndrome and liver disease. Diabetes mellitus carries a very major weight, but the risk of cardiovascular disease is much higher than that of liver disease and may precede liver disease for a number of years. So when it comes to metabolically associated steatotic liver disease or fatty liver disease, we think that about 1 in 4 Americans have fatty liver. Conservatively estimate about 100 million people. And out of these number, there's about 15 to 20% already have inflammation, or we call them MASH, M-A-S-H, like a TV show. And about 1 in 4 of people with MASH may already have significant scarring or cirrhosis. And cirrhosis is the major risk factor of liver cancer. And the risk of develop liver cancer when you have cirrhosis is 1 to 3% per year. So for that reason, patients with cirrhosis from any cause should undergo prompt diagnosis with blood tests, imaging scan, non-invasive ultrasound testing, and even occasionally liver biopsy. Once cirrhosis is established, close liver cancer surveillance with imaging scans using ultrasound, MRI, or even CT twice a year should be implemented. But cirrhosis is not a fixed thing unless it's really end stage. It's reversible. So in order for liver cancer prevention effort to be effective, high-risk disease should be treated promptly, like diabetes, high blood pressure, high cholesterol. And in addition, we should offer vaccine for hepatitis B and medical treatment for hepatitis C and alcoholic liver disease and alcoholic use disorder. Thank you.
Thanks so much, Dr. Nguyen. Really appreciate that overview. I'll build on that and I'll hand the baton to each successive panelist to keep building your understanding of this very complex disease. So I'm a surgical oncologist, and the patients I see are not always surgical candidates, because when you're treating liver cancer, you're often treating 2 diseases like Dr. Nguyen just highlighted. You're often treating chronic liver disease from a variety of causes, as well as a new cancer. And you have to decide, is that cancer, 1, operable based on how advanced the cancer is, and 2, based on the underlying health of the liver. Once you make that assessment, then I often am navigating patients to other providers, to Dr. Chauvin to see if they're a transplant candidate, to Dr. Yofi if they need systemic therapy and immunotherapy, or Dr. Meshikow if they need an ablation or an arterial procedure, or finally Dr. Meyer if they need radiation. And these treatments all make sense in a variety of contexts. So it's really not a one-size-fits-all kind of disease. It's really like more like, instead of buying a suit off the rack, every treatment is a bespoke suit. Everything's got to be tailored to their precise needs, both in terms of the liver function and the state of the disease, but also, what their treatment preferences are, what their underlying health is. The patients I predominantly treat are patients with otherwise normal liver function and who have tumors that are not within the bounds of someone who can get a liver transplant. They tend to either be very normal liver, and so if they have a normal liver and we can remove the tumor, that is often the best treatment. If they have a larger tumor and normal liver function, those are also candidates for liver resection. Liver surgery is complex, it's scary, but it can be done safely. After making an assessment of how your liver will do and how much liver would need to be removed, we can get a sense quickly of what the risk is. We can do this either traditionally through an open incision or increasingly through a robotic approach using small incisions that allow us to accomplish the same thing, but help you recover faster. That involves a complex coordination of care and selection of the best operative approach. It doesn't really matter if we can do it with small incisions if we can't do the thing correctly, which is removing the tumor with a clear margin of liver around it and removing it safely so that your underlying liver can regenerate. One of the amazing things about the liver is that it grows back It's not the part that we remove that grows back, but the rest that's left grows bigger to compensate, like a tree that you pruned. We lose that when patients have underlying liver disease, though, and cirrhosis. And so while surgery is a good treatment, it's not the only treatment. And it can also, while help you, lead to recurrence later on. I think even if we can successfully remove a liver tumor, approximately 70% of patients will have a tumor recur within 5 years. And that's not because we did a bad job. It's because the conditions that led to that cancer to form exist in places in your liver besides that one place, because it's underlying liver disease that really forms these tumors. That's why things like transplant are so wonderful. If you were a transplant candidate, we'll lose no time getting you to Dr. Chauvin and his team, because their recurrence rates, if you're a liver transplant patient who undergoes successful transplantation, is less than 5% in 5 years. And so that's really the preferred method. It's got its downsides, but it's also got tremendous upsides. And we just have to make sure that we select the right treatment for you. So in many ways, while I'm a surgical oncologist and I treat a lot of disease surgically, in liver cancer more than any other disease, I feel like I'm a physician navigator. I have to put a team together for you. And I'm sometimes a spoke on the wheel, and I coordinate with Jared, with Dina, with Ken, with Min, with Josh, to see what you need at this particular junction. We all talk about these patients together at our Temple and Fox Chase combined liver multidisciplinary meeting on every Thursday, just to make sure we're putting our heads together and making the best possible plan for these patients. So with that, I'll turn it over to Dr. Ken Chauvin, who is a transplant surgeon and head of our solid organ transplant team at Temple.
Thank you, Jason. I think you teed me up very well. Our role in this disease management is based on underlying diseases of the liver, like Min has already spoken to you about. When that gets to a stage where it's not safe to operate, we can do a successful operation, which is a liver transplant, where we replace the whole liver with a new liver. It reduces the recurrence rate. The downside is because there are not enough organs for the number of people in need, and that you have to be sick enough to actually be allocated an organ. At the same time, we recognize that the underlying liver disease may be too severe for an operation, but the transplant community recognizes that those patients will do better. And so what is called a MELD score, which is based on laboratory values in the setting of cirrhosis. The system is geared to offer organs to those patients at a reasonable percentage equated with the other liver diseases that we do transplant. That being said, we can't transplant all patients with all tumors because size does matter in terms of the disease burden. If it exceeds a certain size, we can, with our colleagues who you'll hear about, they can intervene and shrink the tumors to make you a candidate for a liver transplant. But as part of being a liver transplant candidate, your other organs have to be able to tolerate a very large operation and all. But as a continuum of care to cure, liver transplant is an option that in conjunction with our colleagues at Fox Chase and the tumor board, we will direct patients there. And at the same time, it's not the right answer for all patients, whether it's age, underlying other liver diseases, or desire not to go through that. We have other options to cure you or manage the disease. And with that, Jason, I give you whoever you're calling on next. Thank you.
Thanks so much. I really appreciate that. Next, Dr. Josh Meyer is going to talk about the role of radiation and how he treats liver cancer.
Thank you. It's a pleasure to be here tonight with you. And I'm going to talk about this in a few different ways. I think one thing to think about is whether you're a patient who's going to benefit from an aggressive treatment of one liver tumor or two or three liver tumors, which we can do with radiation, or whether you're a patient who has more liver disease than that, where we're not able to be so aggressive, but we can still help you by treating large volumes, if not the entire liver, with a lower dose of radiation. Sometimes liver cancer patients even have cancer that spreads to another part of the body, and we can treat that with radiation as well. So radiation can be helpful in all of those different settings. And we have lots of different techniques that we can use to do that. Sometimes we treat patients for 5 days a week for 15 treatments, say, 3 weeks in a row. Sometimes we treat patients 2 or 3 times a week for 5 treatments. Sometimes we treat them with a single treatment. It just depends on exactly who you are. This is back to the same theme that Dr. Castellanos was talking about. Every patient is different, and therefore every solution for every patient is going to be different. We have some new technology we've been using in our department in the last year, which we're very excited about, which has allowed us to treat patients with liver tumors and particularly hepatocellular carcinoma, and do so a little bit more precisely. And to quickly summarize what that is, that we're very excited about, ordinary process for radiation is we have you come in and we do a CAT scan of your body, and we plan your treatments with that CAT scan. And then about a week and a half later, we have you come back in to start your treatments, and you get anywhere from 5 to 15 treatments, let's say. And every time you come in, we line you up exactly perfectly, but we don't change the radiation plan. It's the same plan that we generated the first time you came in for that CT scan. We now have the ability to actually modify that radiation plan every time you come in. So you come in for a plan, and then when you come back for treatment, you get a CAT scan on the treatment table, and we can make adjustments. And if your stomach is more full or more empty, if things are in a slightly different position, if the tumor has shrunk, if you have other things going on that change your anatomy a little bit, we can adapt to that. And by doing so, we can actually spare more liver, and we tend to be able to get a slightly higher dose into the tumor safely. So that's one piece of technology that we've been able to roll out, and we're very excited about it. It's working well, but there are lots of other things that we can do. The other thing that I'll mention is that we work very closely with Dr. Meshkow and his team, and we will often have patients where we can both discuss what the best mode of treatment for that patient is going to be, and sometimes we'll even treat part of it with an interventional radiology approach and part of it with radiation. So this is very much a team sport. We work together very closely, and it's a pleasure to work with all the panelists here. And every patient is different, and we strive to try to find the best treatment for each one of those patients.
Thanks, Dr. Meyer. Really appreciate that. Perfect segue to Dr. Meshkow, who may have the most treatments to talk about. Jared, why don't you take it away?
Jason, thank you so much. So I am Jared Meshkow, one of the interventional radiologists at Temple and Fox Chase. We're part of the multidisciplinary team, and I say team because none of us can do this alone. We all work together very well regarding the treatment of hepatocellular carcinoma. And as Jason and Ken had spoken earlier, and one of my former mentors had said that surgery and transplantation are the true cures for hepatocellular carcinoma. So ultimately, the goal is to transplantation and or surgical resection. But in some cases where the liver disease might be a little bit too much, or they might be such a long wait list, we do offer a number of treatments where we can help bridge the gap and allow for surgery or transplantation. And there, as an interventional radiologist who has a special interest in interventional oncology, we have a number of tools in our toolbox to help all of the other players within the multidisciplinary tumor board. For those that are surgical candidates, we can assist in growing that normal, healthy liver to be able to obtain or surgery or surgical resection, either by compensatory hypertrophy or growing that normal part of the liver in anticipation for the surgical resection, either by portal vein embolization or by lobar Y90, which we'll get back to in a little bit, or for those who actually are transplant candidates, since there is such a long wait for a liver transplant, we have a large toolbox for the treatment of these hepatocellular lesions. And that depends on size, location, and a number of different tumor markers, and well as laboratory results, depending on which treatment paradigm we choose. But essentially, if it's a smaller tumor, we have one option, which is percutaneous ablation, which we usually use microwave. It's essentially exactly how it sounds, where we would use a small antenna or a needle about the size of a pencil tip, insert it under ultrasound and CT guidance into the tumor, and like it sounds, a microwave, we would cook the tumor to get adequate margins with curative intent, and that our goal is to cure the cancer, but there's not 100%, but nearly 100% success rate. Other options, if microwave ablation is not particularly capable, we're not capable of doing microwave ablation, and include transarterial therapy. And similar to Dr. Myers, we use internal radiation therapy rather than outside radiation therapy, and we rely on the goal or the premise that liver tumors have, or the liver has dual blood supply, and we draw on the fact that liver tumors predominantly draw, or almost nearly draw, their blood supply from the arterial supply or the arteries rather than the portal vein. And what we do is we snake a catheter mainly from the groin all the way up through the big artery in the belly into the area of liver with the tumor, and we deliver internal radiation therapy. And the goal is to kill the tumor in its entirety. There may be some particular nuances to this particular procedure, but in some cases where we can't do internal radiation therapy, we might go to a different treatment modality, such as internal transarterial chemoembolization or bland embolization, which are other little particles or chemotherapy substances that we can deliver via that arterial route directly to the tumor in order to bridge these patients to transplantation, which would be the ultimate goal, is to get them within Milan, have a certain number of tumors or a decreased amount of size, so we can get you to the ultimate cure, which is liver transplantation. And as Josh also said, I think we all work together really, really well. I think that this particular area of treatment, we work with radiation oncology and oncology, surgical oncology, and we can all blend our practices in order to get the best treatment response. And sometimes that would include transarterial chemoembolization with radiation oncology, combining local regional therapy with immuno-oncology, which is systemic therapy. And I think that the future is bright for the treatment of liver cancer. And by working together, we'll probably get the best response.
Thanks so much, Dr. Meshkow. So you can see, compared to the rest of us, the IR is like the Cheesecake Factory. They got like an option for every situation, and then they have a huge help to all these patients in a variety of situations. And finally, with the most exciting new treatments, we'll talk about systemic therapy and immunotherapy with Dr. Dina Yofi. Dina, why don't you guide us through how you treat liver cancer?
Hi, everyone. I'm excited to be able to join this year. So I give systemic therapies, which mean treatments that go everywhere in the body. So they're not localized like the radiation or the treatments that Jared was just talking about. So most of our therapies are given through an IV or intravenously. Historically, we actually didn't have a treatment for liver cancer until 2008. And then it took another 10 years to find a better drug. And then things really changed over the last 3 to 4 years. We've had a lot of movement in the treatment of liver cancer, which is really exciting. So in 2020, a drug combination got approved that is called atezolizumab, which is a type of immunotherapy, and bevacizumab, which is a targeted therapy. So the targeted therapy, bevacizumab, targets, or it tries to prevent the cancer from growing new blood vessels. So that's kind of how these cancers sustain themselves. And then the immunotherapy piece activates the patient's own immune system to try to recognize the cancer, which has been hiding out from the immune system. And then more recently, in the last 2 years, we had a dual immunotherapy got approved called STRIDE. It's 2 kinds of immunotherapies that adding a second one kind of makes the immunotherapy work even better. So those are our frontline options. So in people who have untreated advanced liver cancer, that's generally what we go for. They haven't been compared to one another. So it's, again, the theme of everything is that these are very personalized and individualized treatments. So depending on liver function, if there are varices as a result of the cirrhosis, we kind of tailor the therapies to the patient, or any sort of other medical problems that might limit one option and make another one seem better. And then just at our most recent conference, we had new data about combining some of the treatments that we do in interventional radiology with immunotherapy and then this targeted therapy. And last year there was data incorporating this systemic therapy after surgery. So we have a lot of exciting stuff, and we're hoping to open 2 clinical trials at Fox Chase and at Temple. One is looking at adding a second immunotherapy that's pretty novel called a TIGIT, adding that to atezolizumab and bevacizumab, that targeted plus immunotherapy. And then I'm hoping to open a clinical trial that looks at combining either of those frontline therapies with some targeted therapies. A lot of the data that we have comes from Asia or Europe, and we know that the patients in the US with liver cancer tend to be underrepresented in a lot of these major trials. So we want to have better data that is more applicable to the patients that we actually treat, and that's kind of the goal of that clinical trial. So a lot is changing. It's really exciting to be able to offer our patients more. And these multimodal therapies are also evolving, which is really exciting.
Thanks, Dr. Yofi. And just, I've been at Fox Chase for 4 years now, and it's in that time we've seen the change and addition of immunotherapy, and we have seen some really amazing responses. It's just something we didn't used to see. So really every aspect of the treatment is changing so fast, and we have a really well-developed team here to take care of you and however you may appear, your friend or your loved one. So we have a few questions now. I'll start. I'm going to assign them to the expert, I think, who can answer them the best, and you just keep them coming. And when we're done, we'll end the program, and then you can always contact us at any time. We'd be happy to touch base with you. We did get one question by email about transplantation in a very specific circumstance, but our first question is also about transplantation that we just got in the chat. So I'm going to give Dr. Chauvin a chance to talk about transplantation. And Ken, another question asked, does age factor into the liver transplant options? So I think it's a great question. And Ken, why don't you illuminate kind of who may be a candidate for liver transplant and how we decide that?
Age is a factor, but not an absolute indication. More often, it is one of many factors like heart disease, lung disease, and all. Obviously, frailty is more the assessment. People are being transplanted with livers into their mid-70s now, whereas years ago, I would have aged out already when I first started transplanting. So age is one of the multitude of, can you get through the operation, and would you benefit in life years saved by having a liver transplant?
Thanks so much, Ken. And I will say, Ken's brought a refreshing vigor to the program. And so, some programs will say 70 is a hard no, but really, I think it's Ken said, it's, age is just a number. Who are you? How are you? And that makes a big difference as well. And the next question, I think I'm going to assign you, Min. Okay. This is about family history. And does it play a role in liver cancer? And then is there a link between genetics and liver cancer?
Could you repeat the question?
Of course, of course. Does family history play a role in liver cancer? And then they're asking about any links between genetics and liver cancer. But I think the family history one's interesting, and maybe you can speak to that.
Yes, I think so. So let me get the one that with genetic And liver disease, of course, there's certain liver disease that have genetic component that much rarer, and I will come back to that later, like hereditary hemochromatosis, which is iron overload, or Wilson's disease, or alpha-1 antitrypsin. Those things that we didn't discuss tonight earlier because it's very rare, but they have a genetic component. But the familial aspect of liver disease are interesting. For example, hepatitis B. It has a lot of vertical transmission from mother to children. And that's why in some other parts of the world, there's families with these infected patients. Nowadays, because of effective vaccine from Dr. Brumberg's work, we get vaccinated, almost universal program for all the children that go to school. So we hope that to reduce the reservoir of chronic hepatitis B patients. In terms of, you talk about metabolically associated fatty liver disease, then there may be a component, maybe a genetic component that like increase the chance of fatty liver, like in East Asians with that PAMPLA gene that can tend to increase abdominal obesity and causing worsening fatty liver disease. So there's always a component of that, and we're learning more and more about it, but there's nothing that we offer in the clinical practice on a regular basis.
Thanks, Dr. Nguyen. Our next question is about what are the common symptoms of liver cancer? And so one of the interesting things about this, unless you have liver dysfunction, meaning your liver is not working well, they can be quite silent because the liver, you don't really feel anything going on in your liver unless it's causing lab abnormalities. And so you may have elevations in certain labs. Other things that can happen when your liver is diseased, your skin can change color, you can become jaundiced. You may have GI bleeds because the blood's trying to find a way around the liver. A lot of times we catch these cancers in patients who are at risk by screening them. So patients with hepatitis B, like Dr. Nguyen just talked about, or who have cirrhosis that's known, they get periodic ultrasounds every 6 months or so. And we have to do that because the cancer doesn't cause any symptoms. It'll just arise in the liver and has to be found on imaging. So we really rely on scans a lot. And oftentimes we diagnose patients just incidentally based on a scan they get for some other reason, like abdominal pain or things like that. So I think the symptoms can vary, and they often are mostly tied to what the underlying condition of the liver is, unless they become very large. Dina, they have a question about clinical trials, and I know you mentioned the two. So what clinical trials are currently available for liver cancer at Fox Chase and Temple?
Neither of them are open right now, but we're in the process of opening them. So the first one that will be available is an international study. It's open in 4 countries. It's based on preliminary data that was presented at one of our main oncology meetings last year. But it's combining this backbone of atezolizumab plus bevacizumab that's been around for the last 3 to 4 years. And it's adding a second immunotherapy. We see that improved responses. So we're hoping to open that in the next couple months. And then after that, our clinical trial that I'm leading, but collaborated with everybody on this call and has helped me bring this trial to life, is doing systemic therapy. So either the atezolizumab plus bevacizumab or that double immunotherapy called STRIDE. So we do that, and then we try to, it's generally for advanced unresectable disease, but that hasn't spread widely throughout the body, so that we can still target spots in the liver. So we'll give people a couple of doses of this systemic therapy, and then after we all kind of put our heads together, we decide, is radiation more appropriate, or do they get one of these interventional radiology procedures? And then after that, we would continue systemic therapy. And then if any kind of new spots in the liver popped up, we could address those without having to switch to another treatment altogether. So hopefully in the next few months, we'll have these available.
Thanks, Dina. Thanks for that overview. Next question is, how does alcohol use increase the risk of developing liver cancer? I hate to keep picking on Dr. Nguyen, but I think you're the best one to answer this. Can you tell us a little bit about how alcohol harms the liver and leads to liver disease?
Sure, alcohols can cause inflammation and fatty accumulation in the liver, and it can, when you have inflammation in the liver, it causes scarring. And so over a period of time, you were leading to cirrhosis. So cirrhosis, again, is a major cause of liver cancer.
Great, thanks so much. The next question is about bile duct cancer, which kind of gets lumped into liver cancer. So that's a great question. I'm glad someone asked that. Is it statistically the same as liver cancer? So, while you can have a bile duct cancer that starts in the liver primarily, liver cancer and bile duct cancer are considered separate cancers. Now, sometimes the cancer can have features of both. Those are very confusing and rare, and we won't really confuse things by talking about that. But liver cancer is much more prevalent across the world and in the US than bile duct cancer. But bile duct cancer is increasing in prevalence, and we don't know why. Bile duct cancer can arise within the liver, outside the liver, and then even deep down near the pancreas, because the bile duct goes from tiny little bile ducts inside your liver to a main bile duct that goes all the way into your intestine. So different disease, very different treatments, actually a very similar team who treats them. But we'll have to have another Together Facing just for that, I think, because that deserves its own forum. Are there foods to avoid with liver cancer treatment? Oh, I don't know anything about that. Maybe anyone want to take that before I just give it to Dr. Nguyen again? Dina, do you advise patients to avoid any certain foods during systemic therapy?
Generally not, especially with these, if people are getting kind of more traditional chemotherapy, I might say don't have like raw sushi or raw meat. But these, our goal is for people to maintain their nutritional status. So I kind of make up for giving them treatment for their cancer by saying you can eat whatever you want. But yeah, there's not really any restrictions, especially with the treatments that we have.
I think, how about you, Kent? I think probably you would have the most, because of the immune suppression, say about diet, during, which liver transplant is a liver cancer treatment. So what kind of dietary restrictions do you have on those patients, if any?
The dietary restrictions, Jason, are primarily health maintenance because they're on steroids, some liver less so than other organs, and then agents that actually metabolize the anti-rejection medicine. So no grapefruit juice or other things. So there's a list of dietary that either can promote elevation in the levels or down, but it's specific to the drugs that they're on. Otherwise, it's normal, healthy living.
That's great. And then is there a screening test for liver cancer in people at risk? So yes, ultrasound is predominantly used if you have hepatitis B or you have known cirrhosis. And so those are the folks we know that are at very increased risk for developing liver cancer. We screen them every 6 months. That leads into the next question, Min, and I don't know if you have any insights into this, because fatty liver or MAFLD, as we now call it, is increasing, and it does put you at risk for cancer or liver cancer, but we don't really know if we should screen them or not. So I think that's a topic of debate amongst ourselves. But does fatty liver have any symptoms, any particular symptoms?
Fatty liver itself is just a consequences of the metabolic disorders that occur in the body, like diabetes, high blood pressure, high cholesterol. The thing that you really worry about, again, to emphasize, is make sure its cardiovascular disorder has been addressed. You're more likely to have a heart attack and a stroke with metabolic syndrome than a liver disease. But when to come to liver disease and you have cirrhosis, the thing is nowadays we have great scan that can try to give us whether the liver is scarring or not. So we want to define whether you have cirrhosis or not. So nowadays there's non-invasive, not painful ultrasound. Take 15, 20 minutes of your time with ultrasound elastography or FibroScan. We have MRI elastography, which is less likely to be paid by for insurance, probably more expensive. And the other two, the ultrasound is very cheaper. And we can tell almost right away whether you have significant cirrhosis or not. And we don't need to do a liver biopsy. And that's important. And nowadays, almost like everyone come in with a host of reason for abnormal liver function test, we're probably going to do a baseline FibroScan. We can do formula in the blood test called FIB4 or things like that to kind of quickly calculate in our head what is the chance that you may already have cirrhosis.
Thanks for that. I appreciate that. I learned something there too. Josh, we have a question about when radiation therapy is used for liver cancer. So we'll focus on the radiation therapy you deliver.
Yeah, so radiation therapy can be used in a variety of situations. There are some patients who, when you look at their CAT scan, when you look at their anatomy, the tumor and the size of their liver and so forth, they would be good surgical candidates for Jason or for Ken. But because of other health issues that they might have, maybe they have some heart disease or maybe they have some lung disease, surgery is going to be just too risky. And so we can treat those patients and treat them aggressively, and we can even cure those patients. And then there are patients who have a cancer that's just too advanced, that's too large or in a bad spot where they can't get surgery. And sometimes they can't get one of Dr. Meshkow's interventions either, and we can treat those. And then, there are patients who have disease that's a little too advanced for us to actually be curing, but we can still help them. We can still control the disease and help them have fewer symptoms. As has been said tonight, most liver cancers, when they're small, they don't cause any symptoms at all. But eventually they can start to cause some symptoms. Nausea or pain are probably the most common. And we can treat those patients too with a gentler treatment that is more likely to help them than hurt them, although it probably won't cure them.
And then to dovetail on that, Dr. Meshkow, when do you utilize radiation? And he uses radiation a little differently. So I'll explain that again, and then how you use like those patients.
Sure. So similar to Dr. Myers, we do reuse radiation, but rather than from an external source, our goal is to deliver radiation from inside the body out. So when we have patients that are a little bit bigger than microwave candidates, so sometimes lesions or tumors that are greater than 3 centimeters or centimeters, or those that are maybe a little bit smaller but in precarious locations where we can't safely put a microwave antenna, we would consider internal radiation therapy or CERT. And our goal is curative intent, like we've talked about before. So there are multiple different clinical trials, and I won't go into the nitty-gritty of it, but essentially the goal is to deliver a very, very, very high dose of radiation internally to the tumor, and it essentially burns it from the inside out to essentially cure you from that disease. We can also provide or offer radiation therapy, again, for hypertrophy of the liver if you're a surgical candidate, or for palliation or to increase or improve your clinical response if you're not a surgical or transplant candidate. So everyone's a little bit different, but radiation internally has a lot of different options.
Thanks, Jared. Dina, are there types of targeted therapy for liver cancer?
So I think that's going to be an area that hopefully we'll see some growth in the near future. Right now, none that I'm aware of. A lot of the time we diagnose these just with imaging alone without sampling the tumor itself with a biopsy. We're trying to, or our hope is to be able to get more biopsies because there's a lot of advances in profiling, called molecular profiling, looking at the mutations in the tumor itself, and some of those can be targets. There are some drugs that are approved based on certain mutations, regardless of what kind of tumor it is. So I think once we start looking more regularly and sampling these tumors, hopefully that'll open the door for more targeted treatments. But right now it's just this targeting the blood vessel growth and the immune system.
Great. Thanks for that, Dina. When liver cancer spreads to other organs, where does it spread? So I'll answer that, then I want to pivot back to you, Jared, about a specific question about chemo, embo, and TheraSphere. So liver cancer, it starts in the liver. If it goes anywhere outside the liver, that's metastatic. Unlike other cancers where spread to the lymph nodes is stage 3, liver cancer is considered stage 4 if it spreads to the lymph nodes or the little collections of immune cells next to the blood vessels that go in the liver. It tends to spread to lung, bone, and the adrenal glands. The adrenal glands help you regulate your body's kind of a lot of the hormones. Those are the most common sites, although it can spread in other ways as well. So that's why we typically will get a CT scan of the chest, even though we're just looking at the liver. Sometimes we'll get a bone scan as well. Jared, two patients have questions about chemo, embo, and TheraSphere. One is if it's better than traditional chemotherapy. I'll just kind of say that they've never really been compared and they use them in very different situations. So not so much about that, but maybe if you want to make a distinction between chemoembolization and TheraSphere, and then specifically, can Y90 be used repeatedly is another question.
Sure. So in terms of chemoembolization versus systemic therapy, the goal for chemoembolization is to deliver that chemotherapy either in a liquid form with Lipiodol to that particular area of the tumor, or sometimes what you'll do is you'll have little spheres or beads where the chemotherapy will be connected to it. And the goal for chemoembolization for that is twofold. Is one, to block the blood supply to the tumor and cause ischemia and death, along with leaching off of that chemotherapy agent to the tumor to kill it. So it's almost twofold. In terms of yttrium-90 versus chemoembolization, both are transarterial therapy, but Y90 relies more on the radiation aspects. And the way it's now being described in the literature is kind of like you're putting an army into the area of the tumor, and the more bullets you have, kills the tumor from the inside out. And that pretty much relies on the radioactive decay of yttrium-90. The answer to the other part of the question is, can you do Y90 more than once? The answer is yes. However, there is a finite amount of times you can do Y90, and that one depends on your overall liver function, and two, your lung shunt fraction. And that means that sometimes, in every case that we do Y90 or transarterial radioembolization, there will be some radiation that ends up in the lungs through intra-liver shunting. And there is a threshold dose that we don't want to go above, because then we put you at risk for radiation pneumonitis and issues with the lung function. But the short of it is, yes, we can do Y90s multiple times.
Right. Thanks for clarifying that. Got two questions for you, Dr. Nguyen. They're both related to liver function. What does it mean if your liver enzymes are high? Does it mean you could have liver issues? And would a regular hepatic function panel be of use in trying to detect liver cancer early?
So the first one is liver function tests. It usually there's a range, but nowadays we in hepatologists even think that even at the upper limit of normal, liver enzymes can be high for certain patients, because we have to look at the patient as a whole. So we would look to see if you have diabetes, you have high blood pressure, you have high cholesterol. So your ALT may be 33, which is still normal limit, but it's still high for you. Okay. And then the second part of the question is how to address that. Jason?
Yeah, it would routinely getting a hepatic function panel be of use in trying to detect liver cancer early.
Okay. Liver enzymes, if you do liver enzyme, you cannot detect liver cancer. It's probably be better to go to your regular doctor's office and check liver function tests. If they stay persistently elevated above what they thought is to be normal, upper limit of normal, then you want to look into it. A lot of patients have elevated liver enzymes, not because they have any problems so much with the factors that I mentioned earlier in the talk, but it's more like because they take over-the-counter medications like, multivitamins is something come to mind, anti-inflammatory agents for, your joint pain. Those things can mess up your liver. But when in doubt, please check it out. Check it your doctor. And if you need to, see a hepatologist, because we have things that we can start checking baseline liver for you to make sure your liver is still in good shape.
That's a great point. We don't want to make everyone think just because you may have a little bit of abnormality in your liver function test, you've got liver cancer and you got to go see Ken and get a liver transplant. There are many, 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 many reasons to have some slight alterations there. Just, it's a license to take great care of yourself and to see your doctor and make sure everything, can be done. And sometimes they're just, personal story time. My wife had a slight elevation in her bilirubin. This is like a hepatobiliary surgeon's nightmare because all I think of is the worst things. But there are conditions in which she has, and I made her get genetic testing to be sure, but where you have normal elevations in the liver enzymes and they're completely normal. One is called Gilbert's disease. So there are reasons to have completely normal elevations in your liver enzymes that are just normal for you. So don't take away that everyone's got slightly abnormal labs has got a bad problem. What effect does radiation therapy have on the body and other organs, Josh?
So it's a good question. It really depends on exactly what part of the body we're treating, and what radiation dose we're delivering, and how tightly we're able to control that dose. So in the case of treating liver cancer, as long as we can keep the high dose region within the liver, we're very well able to spare enough normal liver that patients should have very few long-term side effects, and frankly, even don't have a lot of short-term side effects besides maybe being a little tired during radiation. If we're treating a different part of the body, though, it'll be different. Can sometimes cause a lack of appetite, sometimes cause nausea, sometimes cause diarrhea. It all depends on which part of the body we're treating, but most of the time we can deliver this treatment in a way that's very tolerable for people with a pretty low rate of long-term side effects.
That's great. Thanks for that. The next question is about what is the survival rate of liver cancer with surgery? So I'll answer a piece of that and I'll hand it over to Ken because I think we should really talk about the survival after liver transplantation because a lot of patients come in scared of that, which is by far the best treatment if you apply for it, if it applies to you. But if you have normal liver function, then the survival after surgery, it can be thought of two different ways. Just the short term, like what's the risk of surgery, and then what are your long-term outcomes? So in the short term, we're only going to operate on patients who have normal liver function. So it really depends on how much liver we're removing. We think of a major liver surgery if we're removing more than half of the liver, and minor if we're removing less than that. But again, it really depends on your underlying liver function. But if we're removing more liver, the risk of surgery is higher, and liver surgery is pretty intensive and demanding on the body. I think the risk that we worry most about is liver failure after surgery. So it's 1 to 5%, depending on how much liver we remove. And those are the higher end, but I think it's better to have a higher idea of the risk. I think it's an important complement to this. How long do you live? So if you get these surgeries safely, which the vast majority do, life after surgery is really dependent on if the cancer comes back. The liver cancer tends to come back in two different ways. One, immediately, it has to do with that cancer that we removed. And that usually peaks at around 1 to 2 years. And so that's when we're worried about the tumor that we just removed. After that, there's usually a little dip in recurrence. And then year 4 and 5 is when we have concern for new tumors. Again, when we operate on a liver for liver cancer, it is not a healthy liver, even if it may function like a healthy liver, because it's had some kind of chronic damage, either from alcohol, hepatitis, or other causes. And those conditions that led to one cancer can lead to others. And so we have to remain vigilant and screen those patients for a long time. It may be that you have surgery and then you get treated by Dina, Josh, Jared, or Ken, or someone else down the line. So the treatment may be iterative. The recurrence risk I talked about earlier, 70% at 5 years. That's very high. But we have a lot of things we can do at that point. And so then we just kind of reset and go from there. Dr. Shalvin, tell us about the risk of surgery and survival after liver transplant.
Thanks, Jason. Looking at liver transplant in terms of that, we kind of reported out at 1 and 3 year survival because of, and it's the liver transplant for liver cancer is lumped in there because that's just how transplant and organ programs are allocated. With that being said, the 1 year survival from a liver transplant, taking all comers, including the immunosuppression, risk of infections and all, is around 90 to 92%. Now, for the patients who are doing it for cancer and who are less sick, going into it, I mean, these are people who have essentially liver failure. That statistic includes. So for this group, though, it's higher. It's around 95%. I mean, there's an inherent risk of removing the entire liver. It's a bigger operation than a liver resection. They're both very big and they carry with them a mortality. But once you get over that early 30-day mortality, you have a very high survival. And then at 3 years, it's around 80–85%. And the difference of a liver transplant with surgical resection where the cancer can come back, it still has the risk of coming back because of cells and all the same biology, but we remove the entire organ that has a chance to develop the new tumors because of the underlying disease within the old liver. So that is gone. So it would be only stray cells that are the real risk here in liver transplant. So that's why liver transplant, if you qualify and everything else, has a higher short and long-term survival because you've removed the underlying risk of why you got the cancer to begin with.
Thanks, Ken. I appreciate that. And my last question, and I appreciate all the questions. There's a lot of engagement and really made a lively discussion. Why would someone come to a comprehensive cancer center like Fox Chase for liver cancer treatment? Well, I think this panel is the endorsement of that. We have all the members of the team you would need and all the programs you would need to navigate your care and to build a team that you need for your personal circumstance. I think we want you to get the best possible care. This is not the only place that treats liver cancer. We don't want you to feel like that. We want you to go to a place where you're comfortable. Sometimes convenience plays a role in that. We have to be near your family. But we've got every basic tool you'll need to treat this disease. And so I think that's an endorsement, and it's in our DNA. We talked about Dr. Bloomberg. I'll leave you with one final anecdote. If you visit us and you go to our cafeteria, you may notice a pair of woodchucks and a little statue off to the left as you enter. And no one knows why those are there, except for the history geeks. I think Dr. Meyer probably knows. Groundhogs are a wonderful model for liver cancer. We found that out when Dr. Bloomberg sent someone to the Philadelphia Zoo to study chimpanzees, and the zoo veterinarian told him, "Oh, you're interested in liver cancer? Groundhogs, they develop liver cancer." So there was a long tradition of rounding up groundhogs in the surrounding area for the labs to study liver cancer and hepatitis B and how it transformed into the liver cancer. So it's embedded in this center, and we're very proud to treat it and to treat it well and to treat it how you need it to be treated. So with that, I'll thank all the panelists. I'll thank all the attendants and our team who put this together. Thanks again to our sponsors, our gold ribbon sponsors for AstraZeneca and Novartis, our silver exhibitor Eisai, and our bronze exhibitor Exact Sciences. And then thank especially to the American Liver Foundation and Blue Fairy, the Adrian Wilson Liver Cancer Association. I urge you to check those foundations out for support, literature, education. There's even a walk in New Jersey coming up. We're begging for a Philly Liver Walk. But thanks, guys, and please reach out to us with any questions. However we can help, we'd be happy to help.